Okay, now let's move on to another case, similar in nature, but I think it'll take us a little bit further into that treatment paradigm. And I'm going to have Shannon go ahead and just give us the context of this case, and then we'll
Absolutely,
open
no problem.
for discussion.
So this is a 55-year-old African-American woman who presented to her gynecologist complaining of abdominal pain and bloating and weight gain, the usual suspects. Her past medical history is significant for mild hypertension, which is managed with hydrochlorothiazide, type 2 diabetes managed with metformin. She does have a family history of a mother who died of breast cancer at age 54, a maternal aunt who died of breast cancer at age 65, and a father who is alive with prostate cancer. Physical exam significant. Her abdominal abdomen has a bilateral lower quadrant tenderness. She does have a positive fluid wave for ascites. Her pelvic exam demonstrates a large nodular mass on the left side. Imaging is obtained. CT of the abdomen and pelvis demonstrates bilateral adnexal masses. The left side 8 centimeters, the right 3.5 centimeters. She has ascites and diffuse peritoneal carcinomatosis. She does undergo a paracentesis of 4.5 liters, and her cytology is significant for high-grade adenocarcinoma. Core biopsy of the omentum is then obtained with a high-grade serous carcinoma, and her CA-125 was elevated at 305. She gets treatment, so she undergoes an exploratory laparotomy followed with an omentectomy, BSO, appendectomy, and resection of all gross pelvic nodes. She does have microscopic residual disease of R1, and germline molecular testing demonstrates a BRCA1 alteration. Her final path is high-grade epithelial ovarian cancer involving the omentum, ovaries, and 5 lymph nodes. And that's her.
Okay, great case. So let me ask you a couple things. I mean, obviously her past medical history is screaming for a BRCA mutation, right?
You think? No.
Young, huge family history, is almost overboard. But we looked at this, and I understand it's been looked at in many places as well. Like, how reliable is the family history? So, like on the first case, we had a 44-year-old with a negative family history. How reliable is family history for?
It's fairly reliable, but you're going to miss a big proportion. So about 45% of patients that have a BRCA mutation don't really have any significant family history and are not what we would consider of young age. So I think over 50. So it's really interesting. So that's why we really pushed for universal testing of all patients with any high-grade ovarian fallopian tube peritoneal cancer, because there's a large catchment outside of just using these clinical factors.
Yeah, I was impressed by that. Back in the day, we used to use these computer algorithms that would, we would bring in bits of family history, and then it would come spit out a likelihood for a BRCA mutation. And the ASCO policy at the time was that it had to be 10% or higher. And so we did a study and saw that in that group of patients that were predicted to be 10% or lower, that we ended up missing like 25% of our mutations. I mean, so I think and I think it just drills home the point that, as you mentioned, is that we just should be just testing everybody. What's your guys' policy?
Well, we're trying to test everybody with paired testing up front.
Yeah.
So germline and somatic. Currently the commercially available entities, they'll leave some holes and opportunities there. So, we're trying to figure out the best way to do it. We're actually in the process of changing our algorithm right now. And so if we have someone with neoadjuvant chemotherapy, we'll often wait to test them until their surgery so that we'll have more tissue rather than just a core biopsy. So often the core biopsy is not adequate to perform somatic testing on. So we're trying to test everybody with germline and somatic at the time of surgical diagnosis.
Surgical diagnosis, okay. So this patient, I was going to ask you this before, but let me get to it now. So she had a paracentesis done, and then she had to have a core biopsy. So first of all, why did she have to have both? And how confident are you on the cytology from the fluid?
So this is probably another one where you're going to stump me, but because it sounds like it's something you guys all know about, that maybe the paracentesis is unreliable. But obviously as a pathologist, you always hear that the tissue is the issue. You always want more tissue, and so ideally for the patient, you don't want to have to go back in if you can do it off whatever is a paracentesis, and do the immunohistochemical workup that way. For this patient, it seems like they had to go back in for some reason, obtain another biopsy, and maybe they just didn't have enough tissue up front. I'm not sure. But
it seems like a fair amount of times with the paracentesis alone, you just get an adenocarcinoma diagnosis, which is fine, because generally for the upfront treatment, we're going to treat these patients the same. But personally, I mean, you want to know if they have clear cell or endometrioid, or because there's going to be such a different molecular milieu in those patients, and
It's
so
become
that's
standard in
why
our
I like it.
institution that we only rely on the core biopsy.
Yeah, the problem is the timeliness of the core biopsies from our interventional radiology colleagues. Now, I would want it on this patient because their CA-125 is only 350. Now, we don't know what our CEA is, but it does bring up the question of a non-serous histology, which may or may not make any difference in your management, but it would be nice to know.
Yeah, and I think that given that they had such a large volume of ascites, I wonder if it was done just for that purpose. It was symptomatic, but at the time of surgery, as when we have a patient with a large amount of ascites, we'll end up there draining them at the time we do the incision, and then we go from there. But however the sequence was done, they end up getting both of the tissues and then ultimately made that diagnosis. But yeah, I was also thinking, with the 44-year-old, that clear cell or endometrioid
Right,
tumors that I'd be thinking
absolutely.
about as one of those
Absolutely, yeah.
alternative histologies.